Hello, everyone, and welcome to today's webinar. My name is Michelle Woodhill, and I'm the Senior Director of Development at Dr. Susan Love Foundation for Breast Cancer Research. For those of you who are joining us for the first time, I'd like to take an opportunity to introduce you to our organization. Dr. Susan Love challenges the status quo to end breast cancer through innovative research and improve the lives of people impacted through education and advocacy. We drive collaborative, cutting-edge research with non-traditional partners, shed light on the collateral damage of treatment, and actively seek ways to diminish it and interpret science to empower breast cancer patients. Many of the projects at the foundation undertakes are designed to increase our understanding of the human breast, where breast cancer starts, what enables malignancy to occur, with the ultimate goal of developing methods to prevent it in the first place. The foundation is also committed to participation in research that has the potential to positively impact the lives of people who are at risk for or who have had breast cancer. Breast cancer happens in people, so research needs to be done in human beings, and that means men, women, non-binary people, everyone who gets breast cancer. Our Love Research Army is committed to encouraging and facilitating breast cancer research in all people, regardless of age, race, gender, sexual identity, with or without a breast cancer diagnosis. We are committed to thoughtfully engaging our members by providing them with ongoing real-time access to an array of studies. Today's webinar is part of the Love Research Army study series, where we invite the researchers who recruited participants from the Army to present their findings to our community. Joining us today is Dr. Nishant Kumar, who will be presenting the results from his study titled The Financial Impact of Pursuing Breast Reconstruction. The purpose of the study is to understand the financial experiences of women with breast cancer who choose breast reconstruction after a mastectomy. The initial call to action for this study was on October 10, 2019. And the researchers closed enrollment on September 17, 2020. The study enrolled 920 participants, many of whom were sourced through the Love Research Army. Dr. Kumar will be available to answer specific questions related to his study from our viewers at the end of the webinar, so please submit your questions using the Q&A box. While we will try and answer as many questions as possible, please note that we may not be able to address every question today. I'll now turn things over to Dr. Kumar.
Well, thank you, Michelle, for that introduction, and thank you again for the opportunity to present our study findings today. This is truly a unique platform to present these findings on, so I'm really grateful to be able to share the results with you and the members of the Research Army. Before I get too far ahead, I definitely want to say a special thank you to all the participants that made this possible. We always say we've got to thank the team, and most importantly, the members of the Love Research Army that participated in the survey study and generated the data that we're going to present here today. I think the broad mission of the Susan Love Foundation, as well as the Army itself, to really advance breast cancer research is truly meaningful, and it makes a huge contribution to the literature and influence how we deliver patient care when it comes to breast cancer care. Couple of thank yous to the other members on the research team. So Dr. Momo is a plastic surgeon here at the University of Michigan, and Dr. Berlin is a co-resident with me. We're both plastic surgery residents in training. This is an area of research very close to us as we're all involved with breast reconstruction. And I'm excited to show you guys what the study results have been so far. The other members I want to thank are Dr. Hawley and Dr. Jaxie, from the Department of Medicine and Department of Radiation Oncology. They've done a lot of research here at the university within financial toxicity, broadly in cancer care, as well as specifically within breast cancer care. And so their expertise in developing our surveys and our instruments were particularly instrumental. So broadly speaking, for women that are diagnosed with breast cancer that need to undergo breast surgery, the two main options are lumpectomies and then mastectomies. Lumpectomies involve breast tissue, just a portion of the breast tissue being removed from the breast. Mastectomies, on the other hand, typically involve removing all of the breast tissue. And there's different flavors of mastectomies. There are mastectomies where the nipple can be preserved as a nipple-sparing mastectomies, and then a traditional simple mastectomy where the complete nipple areolar complex is removed, as well as the skin overlying the breast tissue. Now, obviously, clinical decision-making is done on an individual basis. These are usually following national guidelines and recommendations. And often these are done in multidisciplinary teams with several providers representing different specialties and with the patient to determine the need for chemotherapy, radiation, the timing of these interventions around breast surgery. In some cases, women undergo genetic testing for their breast cancer and may undergo a prophylactic mastectomy on the non-cancer side as well. So there's a lot of complexity in this process. When it comes to breast reconstruction, this is the area that gets me excited as a plastic surgeon. For women that undergo large mastectomies or large lumpectomies that want to pursue breast reconstruction, several options exist. As we inform patients in our clinic, pursuing no reconstruction is an option as well, and I want that to be very clear. We tell a lot of women in our clinic, flat and fabulous is absolutely a route to pursue for any women based on their individual choices and preferences. However, for women that do want to pursue breast reconstruction, several options exist. Many women may undergo implant-based breast reconstruction. This is either done in a single stage, meaning one operation where implants are placed directly to reconstruct the breast, or in a staged fashion, meaning at least 2 operations are required, where a tissue expander is first placed, and then a final implant is placed at a second operation. In some cases, women require a combination of implants and their own body tissue, if, for instance, they're undergoing radiation. And that's often performed where an implant is placed and muscle from the back, the latissimus, can be used to provide some additional protection and coverage. Another very popular method of breast reconstruction is autologous breast reconstruction. Traditionally, about using muscle from your abdomen was the preferred option for this. And this has been replaced with a slight modification, or the DIEP flap. That's just named after the artery that is used to reconstruct the breast. But we can really get tissue now from your abdomen, from the buttock area, or from the inner thigh or the back of the thigh to reconstruct the breast mount. Again, much like breast cancer surgery, breast reconstruction involves significant discussions with the patient as well as the team to really determine the best choice for the patient. I apologize again if I do get cut off because I have noticed a couple of flashes here, so just bear with me with that. In terms of the timing of reconstruction, this can either be performed in an immediate fashion, which means breast reconstruction that's performed at the time of the mastectomy operation, or in a delayed fashion, meaning breast reconstruction is performed after waiting for a certain period, again, determined by the surgeon as well as the medical and surgical oncologist to pursue reconstruction. Fortunately, when it comes to breast reconstruction, it is considered an important component of breast cancer care. And this is where the Women's Health and Cancer Rights Act comes into play. So introduced in 1998, the Women's Health and Cancer Rights Act is a federal law that provides protection for individuals who want to undergo breast reconstruction after their mastectomy. And so under the law, insurance coverage is required for all stages of breast reconstruction, both on the breast on which the mastectomy was performed, but also on the other breast or the contralateral breast for reconstruction, for symmetry. So for some reason, a woman gets an implant on one side and she needs to get an implant on the other side for symmetry purposes, insurance is meant to provide coverage for that. However, despite that coverage, patients are still responsible for paying out of pocket for costs related to their reconstruction. This is typically in the form of things like deductibles, co-pays, and co-insurances. For most patients, deductibles are a minimum dollar amount after which their insurance kicks in. But even after that, they might be responsible to share some of their out-of-pocket costs, either as a percentage amount or as a minimum dollar amount. And this is where financial toxicity comes into play. This is an article, or this image is from an article in the New York Times from a couple of years ago talking about the financial toxicity of illness. Financial toxicity in itself refers to the impact of these out-of-pocket costs the loss of employment income, for instance, and other such factors that cause a financial strain on the individual patient or their family members and affects their well-being or their quality of life. Two of our collaborators, Dr. Jackson and Dr. Holly, have done a lot of research in this area, as I mentioned earlier. And in one of their studies looking at financial toxicity, they found that patients, specifically breast cancer patients, desired more engagement from their clinicians when it came to matters of financial consequences and the treatment decision-making. Again, that's a very individual decision, but it's certainly the general sentiment that they found in their studies. What's more interesting is when they surveyed surgeons and medical oncologists and radiation oncologists on the importance of things such as conversations about cost, the awareness of out-of-pocket spending, and the discussion of financial toxicity, surgeons seem to score the lowest. And so clearly breast surgeons, plastic surgeons can do a better job when it comes to matters relating to financial burden for patients, particularly for the patients that want to know that information. And that's where the motivation for this study came in. And so although the number of women undergoing post-mastectomy breast reconstruction in the United States has seen an upward trend in the recent years, few studies have really looked at what the out-of-pocket financial burden is for patients and what patient perspectives are when it comes to post-mastectomy breast reconstruction. So this study aimed to evaluate whether patients experience financial toxicity that they attribute to their breast reconstruction, how much that financial toxicity was, who was affected by this financial toxicity. Basically, were we able to identify factors that predicted whether you would be predisposed to financial toxicity after your breast reconstruction? And for the women that were affected or that did experience financial toxicity, would this have made a difference to their decision-making? So we specifically wanted to know from women whether now having experienced financial toxicity, would that have affected their decisions to pursue breast reconstruction or pursue reconstruction, but at a different time? And so we decided to study this using traditional survey-based research tools. We used previously utilized surveys that Dr. Jackson and Dr. Holly had developed for their large survey studies and modified those questions for breast reconstruction. Using traditional survey methodology, we went through iterative revisions with these surveys and tested them among patients before finalizing on our final survey items. Our final survey was 33 questions long. It included questions related to demographics of the patients, what their baseline health was, what their breast cancer diagnosis was, what their breast cancer treatment and medical treatment as well as surgical treatment included, and about 13 of the questions related to financial toxicity and quantifying the financial burden of breast reconstruction. For our study, we included women over the age of 18 years, having a history of breast cancer, a history of post-mastectomy breast reconstruction, and being at least 1 year out from their reconstruction. We chose the 1 year time point just because we felt that would fully capture the financial consequences of undergoing reconstruction, but clearly this list is not all inclusive of women and men that may have breast cancer from their diagnosis. When it comes to survey questions related to financial toxicity, we specifically asked whether participants felt worse off in their financial status because of the direct impact of undergoing breast reconstruction. And so the response to that question was used to document financial toxicity. However, to better quantify what that financial toxicity was, because two people may perceive financial toxicity differently, we also wanted to quantify financial burden. And so this is where we dug a little bit deeper into whether patients use their income. Did they use their savings? Did they use loans to pay for their financial expenses related to breast reconstruction? Did they incur any debt from their breast reconstruction? It's important to realize because women were at least 1 year out, and you'll see that most of our women were almost 5 years out from their reconstruction, there's always the possibility of what we would call recall bias, meaning confounding the costs of breast reconstruction with the costs of other elements of breast cancer care. Nevertheless, the way we try to combat this was we constantly primed women by reminding them that these were related directly to breast reconstruction and not to the other aspects of breast cancer care. And so here's what we found. As Michelle alluded to earlier, we had about 922 women that met our inclusion criteria, but we had over 1,000 women that participated in our survey. And so again, huge shout out and special thank you to all the participants in our survey and the members of the Army for making that possible. Most of the women in our included cohort were Caucasian, so about 91% of women were. About 43% of these women had a graduate degree and were about 59 years old. The most frequent combined household income was in the $50,000 to $120,000 range. So about 46% of women were in that range. And nearly 90% of women in our cohort were insured. Specifically, they had private insurance. And that's something important to keep in mind as I share the results with you, to keep in context for women that may not meet this criteria and may therefore feel the consequences of financial burden differently than the women that are included here. When it comes to their breast surgery itself, most women had unilateral breast cancer, so about 86%. Most women, again, the majority, 61%, underwent bilateral mastectomies. So at least one side was for cancer, the other side was either due to cancer or due to a prophylactic mastectomy. And then women, about 73% of them pursued bilateral breast reconstruction. The good thing for us was the type of reconstruction that was most common. About 2/3 of women either underwent a direct to implant reconstruction, or they underwent the staged form of implant reconstruction where they had an expander and then an implant. And those numbers sort of mirror national norms when it comes to breast reconstruction. Nationally, about 2/3 of women pursue implant-based reconstruction, and about 1/3 of women pursue autologous tissue or a combination of autologous and implant. Most of these women were at least 5 years out from their reconstruction. So about 64% of women were in that category. Here's what we found when it came to financial toxicity. Nearly a quarter of women, so about 24%, that's about 1 in 4, reported feeling worse off in their financial status that they attributed directly to breast reconstruction. That's a pretty significant number that was fairly eye-opening to us when we were analyzing our data. We asked women whether they experienced a decline in their employment status and their insurance status. And so a decline in employment status might involve getting a different job, maybe a lower paying job, or having some sort of decline in your current job related to your reconstruction. And we had 11% of women answer yes to that question. When it came to insurance, about 16% of women answered yes to feeling worse off with regards to their insurance coverage directly due to breast reconstruction. We then try to ask the question, how much was this financial burden? And we did this in 2 ways, finding out how much debt women incurred and attributed to breast reconstruction, as well as how much they were paying out of pocket. And just choosing some of the highlights of our data, women that experienced financial toxicity, about 29% of those women had out-of-pocket costs that were more than $10,000 compared to 7% of women that did not experience financial toxicity. That is a significant amount of money that women are paying out of pocket to cover medical expenses despite having insurance coverage. When it comes to non-medical expenses, less than 1% of women that did not experience financial toxicity had expenses that were that high. However, women, about 8.3%, experienced costs that were greater than $10,000. We had other cost categories as well, and I have a more extensive table in our appendix slides if anyone's interested. But across the board, women experiencing financial toxicity were paying more out of their pocket compared to women not experiencing financial toxicity. And when we run statistical tests on that, those differences are statistically meaningful or are more likely not due to chance and more due to actual costs that are incurred. When it comes to debt, about 51% of women that experience financial toxicity attributed current household debt directly due to breast reconstruction compared to only 3% of women. That again was a staggering number for us to witness when we were looking through this data. I had mentioned earlier, one of our big goals here was to identify what type of women, what characteristics, whether it was clinical characteristics or demographic characteristics, predispose someone to financial toxicity. So one of the things we found was younger age. So women under the age of 50 had about a 1 in 3 chance of financial toxicity compared to women over the age of 65 that had about a 15% chance of financial toxicity. Unsurprisingly, having a lower household income or greater out-of-pocket expenses were also associated with more chances of financial toxicity than lower household incomes or lower out-of-pocket expenses. From a clinical standpoint, being on hormonal therapy, which a lot of women that are undergoing breast cancer care was also associated with experiencing financial toxicity. However, what's really interesting is the element of complications. So experiencing a major complication from your breast reconstruction surgery was associated with an increased chance of experiencing financial toxicity. What does that mean? So if you experienced a major complication, and that meant you either had to come back to the emergency room and go back to the operating room, or you came back to the hospital and had to get readmitted, maybe with IV antibiotics, or were readmitted back to the hospital for a prolonged stay, you had about a 30% chance, 29% chance of financial toxicity compared to someone who did not experience that and had closer to a 22 or 23% chance of financial toxicity. Again, that was a statistically significant difference when we ran our stats. That's an important element to consider, especially important information for us as surgeons in guiding our conversations with patients. It's important that patients understand the complication profile of each type of reconstruction that they're planning to pursue. So the complication profile for someone pursuing breast reconstruction using their own body tissue might be very different for that same person pursuing implant-based reconstruction. There might be medical comorbidities such as diabetes or high blood pressure that could be optimized before the reconstruction operation to minimize the chance of complication and then potentially minimize the chance of financial burden down the road. And so that was, again, interesting for us to learn about. And then the final question we asked about was, so what? So what if you experience financial toxicity? Would that have made a difference to women's decision on pursuing reconstruction? Remember, we spoke about this earlier, but not pursuing reconstruction is also a perfectly acceptable option if that's what a woman chooses. However, we wanted to know for women that did pursue reconstruction, would they have made different decisions? Here's what we found there. In general, women experiencing financial toxicity were more likely to respond probably yes or definitively yes to the question of whether they would have decided against a reconstruction. They also answered similarly when we asked them, would you have pursued reconstruction at a different time or a different type of reconstruction? Now, keep in mind here with these charts, overall, more women answered definitively not or probably not, meaning they would have still gone ahead with their reconstruction at the time that they chose it. However, the number of women or the proportion of women to answer yes was higher in the financial toxicity group. That's, again, important for us to understand because we want to minimize the possibility of anyone experiencing financial burden, especially if it seems like it might affect their decision to pursue reconstruction. What's really interesting to us from a plastic surgeon standpoint is even though women said they might pursue a different type of reconstruction, we didn't actually find the type of reconstruction to be predictive of financial toxicity. So it might be more things like the complication factor than it is really the type of operation being pursued that affects the likelihood of experiencing a financial toxicity complication. And so to sum up, this study demonstrated a really high prevalence of self-reported financial toxicity, about 1 in 4 women, in women that were undergoing post-mastectomy breast reconstruction. This is despite representing what we would consider more privileged population in terms of race, income status. Our mean income was higher than what national means are. Educational status. As I mentioned earlier, most women had graduate degrees, and insurance coverage. 90% of the women in our group were privately insured, which is certainly not the case for every woman that's considering breast reconstruction. And this really lends itself to a future study where we can really target these populations and see what the burden of financial toxicity is within that cohort moving forward. We found predictive factors of financial toxicity in this study, as we just briefly discussed, and identified areas that could be targeted to avoid undesired financial consequences. So again, thinking about complications, complications can always happen. However, we can certainly take efforts both as surgeons as well as patients to work together to minimize the chances of those happening. And lastly, efforts need to be made to improve the discussions about costs and financial implications of breast reconstruction. I think it's certainly an individual patient to physician discussion on whether cost should be a part of clinical decision-making. However, for the patient that wants to have those discussions, that opportunity should exist. And now I think more work needs to be done on whether that's being conducted by the plastic surgeon or the breast surgeon, the medical oncologist, or a separate staff member. However, our data at least suggests that these conversations need to be had so that patients aren't dealing with the financial burden of their medical decisions. And that about wraps up my presentation. I again want to thank you all for tuning in and listening to this, and again, the opportunity. And I, again, really apologize for the power cut earlier.
No problem. Thank you so much, Dr. Kumar. We do have a couple questions for you. The first question we have is, were there any findings of the study that surprised you?
Yes, as I mentioned earlier, we did not expect a 1 in 4 prevalence for financial toxicity, especially when we looked at the demographics of our cohort. We were fairly surprised. We were also surprised at how many women attributed current household debt related to their reconstruction. I had mentioned that number was about 51% versus 3 to 4%. That was, again, very eye-opening to us. What often happens is, because the federal law exists, the women's healthcare right to pursue breast reconstruction, the assumption is this isn't something that you need to worry about because insurance will cover it. But what we've learned from this study is, for a lot of women, this is, it's a huge decision to pursue reconstruction, and quite a significant financial decision at that.
Yeah, absolutely. The second question we have is, what is your anticipated end goal once the results of your study are shared with the research and breast cancer community?
Great question. I think, as I mentioned, I think the two next steps for us is finding a way to sample a more diverse population. We're very grateful for the participants that we had, but we also have to recognize some of the limitations of our findings, which is it only represents a sample of women that are undergoing breast reconstruction and breast cancer care. So I think certainly more work needs to be done in sampling a broader population before we're looking at implementing new policies or practices. The second element is, I didn't show some of this data, but we do know that women want more engagement from their clinical teams related to discussing costs. But more work needs to be done sort of on the nuances of that, in terms of who has those conversations, how those conversations are had. Does the patient bring up cost, or does the physician bring up cost? Because the last thing the patient wants to feel is they're being provided an option taking money into account, when in reality, you would think that your medical decisions should be independent of any financial influence. Mm-hmm. And so it's certainly a tricky matter. I think more work needs to be done, but the end goal would be we're able to at least have the resources available for that particular patient that wants to make their medical decisions based on financial factors. That would be our holy grail, if you will.
Yeah, definitely. And that would really help the patient make an informed decision.
Exactly. Yeah.
And we do have some feedback on a participant. Tammy K says that she wants to thank you. I appreciate your study. She participated in this study and is appreciative to see the results.
Oh, thank you. Thank you for participating. I really appreciate it.
Yes, we absolutely appreciate all of our Love Research Army participants. We do have another question. Do you agree that legislating state by state or federal mandated insurance coverage for no out-of-pocket costs for breast reconstruction is possible, i.e. no deductible, cost sharing, etc.?
That's a great question. I think in an ideal world, it would be great if there was coverage available, because as a clinician, as a physician, the last thing I want is financial factors affecting my patients receiving different levels of care or having to bear consequences. You know, it's already a burden to deal with a medical diagnosis, let alone a cancer diagnosis, then undergoing breast cancer surgery, and then pursuing breast reconstruction. The last thing you want is financial decision-making affecting your choices of care and kind of adding to the stress of dealing with a cancer diagnosis. So in an ideal world, I would say it'd be nice if there was complete coverage. Practically, I have to imagine there are a lot of factors at play in determining how healthcare spending is decided. But there's a lot of work that's happening in this space on insurance plans and how insurance plans determine cost towards patients. If it can't be eliminated to zero, maybe it could at least be eliminated to lower percentages, or at least more transparent percentages, so that patients have a very clear understanding up front of what they're dealing with, as opposed to what we call surprise billing, where you suddenly get a bill in the mail that, here's your cost. So just at the end of the day, you just want fewer stressors for patients that are already dealing with stressful situations.
Yes, of course. I think those are all the questions we have. If anybody has any additional questions, please submit them in the next 30 seconds. But I do want to thank Dr. Kumar for joining us today and for partnering with the Love Research Army for this study and presenting your findings. I found it to be extremely informative, and I think our participants did as well. So unfortunately, we are out of time. I will check the question box one more time. That's it. And actually, Dr. Kumar, do you mind stop sharing your screen?
Oh,
so
yes.
that the participants have a better view of you?
Sure.
And if there are any questions or comments, you can email us at info@drsusanloveresearch.org. Tiffany also put it in the chat box if you would like that email. But today's webinar has been recorded, and we will soon post it to our website, which is linked in the chat box for your convenience. And I also encourage you to visit our website at drsusanloveresearch.org if you're interested in learning more about the foundation or making a donation to support our research. So I'd like to thank everyone for joining us today, especially Dr. Kumar, and I hope you all are staying safe and healthy.